One thing I am glad about is the fact that we used to have pictures of ourselves posted on here, and the old one has a lot less gray hair than the present one does. I'm just going to blame all the gray hair I have on the federal government, okay? Because funding lately has been very interesting. And as we enter a new funding period, um, previously, we used to have ups and downs in funding. We've survived it before. We will survive it again. And the best way to survive it is to ensure we're maximizing our resources to the best of our ability. And so what we're attempting to do right now is look at how we can prioritize partner service activities that local and tribal health departments perform, and also ensure that the information we're putting into our surveillance system, WEDS, is as accurate as possible. So that way, when we're doing our quality assurance efforts, we're not having to redo the work over and over and over again. So our agenda today is first, we're going to talk about patient prioritization for STIs. Then we will go into the different kinds of partner services follow-up. We'll also do STI reinfection versus previous infections. Maegan will then go into best practices in regards to documentation of treatment, the STI interview status, and STI closure guidance. So prioritizations for STIs. Now, one thing we do know is that all local and tribal health departments statutorily have an obligation in regards to the follow-up of STIs. There are certain levels of degree and how they can do that follow-up. And you'll want to consult your state statutes and administrative codes to make that determination. However, there's also times that things interrupt that. And we need to be prepared for how those interruptions can be used to guide our efforts into doing partner services for sexually transmitted infections. One way to do that is to ensure that we know which groups of people in our communities are overburdened with STIs. And the way we do that is look at the data. And if any local or tribal health department would like to know about their data, fortunately, the 2024 data is posted on our website. You can always go here to find that. If you want more current or more specific data, you can always ask our excellent epidemiologists. They may be able to help you out. We have one in the audience, virtually and in here. And but another way to look at how we want to prioritize people is not just the amount of disease, but what kind of disease burden that people will have. And so this is an example of a chlamydia prioritization chart. This doesn't have to be used verbatim. This is just an example. You'll note on top that the highest priority are pregnant people. It isn't because there are a whole lot of pregnant people who have chlamydia. It's that chlamydia can affect pregnant people harsher, do more damage than people who aren't pregnant. And so we want to prioritize that group of people so that way we can prevent that long-term damage that chlamydia might not have for people who aren't pregnant. Adolescents and young adults. So that's a group of people where basically it also can harm them more than, say, older adults. But more importantly, this is a group of people that is overburdened with disease. And in effect, what we're trying to say is that we want to reduce the amount of disease in this group as much as possible because A, it will reduce our overall numbers, and B, it will also prevent them more than likely from getting the disease in the future as well. Towards the bottom of the list, you might see 46 years and older. This is a group of people that are out, pregnant people can no longer usually get pregnant in this age group. They usually have more resources. They usually have more access to education. And this is a group of people that is less burdened by chlamydia overall. So. For gonorrhea, we have a similar prioritization chart. There are a few added additions to this. For instance, we have disseminated gonococcal infections, antibiotic-resistant gonorrhea, suspect treatment failures. Again, this is not a group of people that there aren't a large number of people in this group that are getting this. Fortunately, real antibiotic resistance isn't happening in Wisconsin quite yet, please. However, these can cause long-term, like disseminated gonococcal infections. This can cause real damage to people, and to such a degree that, there's an example in Madison-Dane County where somebody actually died of a disseminated gonococcal infection. So, we take these cases very seriously. And if you feel that you don't know how to follow up on this, or you want examples of how to do the treatment and care for these situations, please call the state. We have experts who can definitely help you with how to navigate how to follow up on a disseminated gonococcal infection or antibiotic-resistant gonorrhea and so forth. Chancroid and ARGC, they have their own separate categories. Again, these are very small groups of people. We usually do not see chancroid in the state, and we don't want to see chancroid in the state. And that's why in some ways we consider them a high priority, because if we tackle it early and prevent the spread, it's not something we have to do long-term and follow up on 50 cases next month. So what type of partner services are there out there? Because sometimes when people think partner services, they think it's a one size fits all, and that's not necessarily the case. So the first thing you want to do when doing prioritization is also determine your capacity. Some local health departments may have 2, 3, 4, even more people following up on STIs. Maybe some of the smaller ones have one person that does it half-time because, they've got to do 800 other things besides STI follow-up. So once you determine your capacity, then you want to determine what type of partner services can you perform in that capacity. And so what we have done at the state is develop a prioritization guidance. This will soon be posted on our PCA portal, which all the local and tribal health departments have access to. And what we will do then is, if you have questions on it, we will be more than happy to answer them. But you will be able to see a much longer document than what we're presenting today about this. So this is a chart that can be used for determining what kind of partner services you want to perform. You have the full partner services, partial partner services, and treatment verification only. Now, during a normal routine month of working at the health department, maybe you're doing full partner services for everybody. But then all of a sudden, measles comes. Oh no, we've got a measles outbreak. What am I going to do? Hopefully it doesn't happen. But if that does happen, some of your capacity may have to be used to take care of that situation. If COVID taught us anything, you never know what's coming down the pipeline, and the expertise you have doing partner services may be needed in another area of disease follow-up. So this can go up and down depending on what time of year it is, certain situations. So full partner services, when I talk about full partner services, what I'm talking about is, for instance, you're interviewing the original patient. Maybe you're trying to find them using emails, phone calls. You may even visit their house or the clinic where they're getting treated and having that face-to-face interview with them. We know at the state, especially, that if you have that face-to-face interview with a person, that is the most effective way of doing partner services. You're relating to that person. They see your sincerity. You can usually gauge the truth of what they're saying. It's much better to do this face to face. However, we don't always live in a world where we can do this face to face with everybody. And so maybe we're going to do this over the phone, or we're going to use some other method of communicating with a patient and their contacts. And maybe you are getting all of their contacts, finding out who their partners are and getting them in to get tested and treated. And of course, you're always going to verify treatment because you want to make sure that the person who has the disease is no longer has the disease. That's the benefit of working in bacterial STIs, by the way. You can get rid of them. We also know that sometimes doctors have their own ways of doing things, if I'm being polite, and they may not conform to CDC guidelines. And so ensuring that they do definitely helps prevent the spread of the disease in the future. Partial partner services may be basically you are interviewing the patient. Maybe you're not going to do a home visit because unfortunately you don't have the capacity to do that. And you may not also do partner follow-up because again, you don't have the capacity. But having that one-on-one interview, answering their questions, giving them guidance in how to prevent getting an STI in the future, maybe convincing them to have their for them to get their partners in to get tested and treated, or even talking to the provider and saying, oh, by the way, you know how the patient talked about their boyfriend? Maybe you want to talk to the boyfriend and see if they can come in, something to that along that line, figuring out ways to do the partners, getting them in to get tested and treated without unfortunately being able to do it yourself because again, you just don't have the capacity at this time. And of course, a treatment verification is you're unfortunately not able to interview the patient or their partners. All you're able to do is just verify treatment and maybe encourage the medical provider to, tell the patient that they need to get their partners in, encouraging EPT, finding ways to do disease intervention that because you lack the capacity at this time to, do in the future. So STI reinfection identification. So if a person has previously had gonorrhea and or chlamydia, and then later on you get a lab slip, you want to determine, is this the previous infection or is this a new infection? If the patient hasn't been treated, there's no documentation of treatment in that original infection, we would not consider a new positive laboratory report as a different infection. We would consider that as the same infection, and therefore it gets attached to the previous incident. Where we start getting into gray is when we're trying to determine, is this a reinfection? And you'll see here that there's 3 definite things that help us determine reinfection. But the other 3 ways, and I'm going to go into more detail about this, you may need to find out more information. And so looking at the guidance will help us determine whether or not a person has been reinfected or not. So for chlamydia and gonorrhea, the same infection, again, no documentation of treatment. So any additional laboratory results and new exposures do not matter. The new reactive laboratory report has to go on to the previous report. If a patient has had a reactive test result greater than 30 days from documentation of treatment and has a new exposure, then it could be considered a reinfection. But what you also want to do is consider, remember how I said a lot of this is gray? A culture test is the exception because a culture test can determine if a patient has been reinfected better than NAT testing can. The reason, NAT testing looks for DNA. And DNA can stick around even after the organism has died, as every CSI show has told us. And so when a person has had chlamydia or gonorrhea, the DNA can still be in the place of exposure, and a swab can get that DNA, and it appears that the person still has, the organism still has the disease, when in actuality they don't, which is why we use a 30-day rule. However, if a person has symptoms after treatment, a culture test is much better at determining reinfection because culture tests don't look for DNA. Culture tests grow the organism. And the only way the organism can grow is if it's actually there. And so, because the organism is there, obviously they still have the disease. While treatment failure is possible, more than likely, reinfection is the probability, okay? Because if a person has consistently had reactive test results, even after 30 days, chances are they've reacquired the infection from an infected partner again. Because that partner didn't get it, we weren't able to do partner services for that partner, and they didn't get tested and treated, and they were just ping-ponging it back and forth between each other. We really only want to determine true antibiotic resistance is considered based on evidence. So, I mean, if you have a patient in front of you and they're insisting and you believe them, they've had no sexual exposure since their treatment, and it's 30 days and they keep getting a positive test result, that could be a reinfection. Culture testing can really determine that, antibiotic resistance. Culture testing can help determine antibiotic resistance. So get that done. And if you have a real antibiotic resistant case, please contact the state. We have definite guidance on how to proceed forward with getting that person taken care of and looking at possibilities of, further partner services. A new incident must be created with reinfection. Okay, so one of the reasons why we're talking about this is that there have been instances in the quality assurance of our data that people unfortunately have basically had cases that were a reinfection, but they attached the reports onto a previous infection. They didn't create a new incident. And, and I don't know if anyone was here yesterday, but that wonderful talk we had yesterday about all the numbers is only accurate if the information in our WED system is accurate. So the more accurate that is, the better numbers we're able to give to people. And so if that happens, the WEDS team can definitely take that report off the old incident and help you create a new incident. So that way you're accurately documenting the information in WEDS as much as possible. That gray again. Okay, so pharyngeal infections are a little different than rectal and urinary tract infections. So for instance, we don't routinely screen for pharyngeal chlamydia. It's not advised. We do screen for pharyngeal gonorrhea. And there are times when the pharyngeal gonorrhea test will actually pick up a pharyngeal chlamydia. And so if that does happen, you want to have separate incidences, okay? If it's positive for pharyngeal gonorrhea and positive for pharyngeal chlamydia, you want to have each incident documented in WEDS because those are two separate diseases. Don't just attach one onto the pharyngeal gonorrhea and, ignore the pharyngeal chlamydia. Let's see. Patient documentation of treatment completion. If a reactive test result is less than 30 days from treatment completion, it may be the same infection. Okay. So there's a different burden of proof when it comes to treatment and documentation of incidences in WEDS. If a person is having symptoms and you think there's a possibility of reinfection with the patient less than 30, because they had a test result less than 30 days, retreat, okay? Because we want to make sure that patient is as healthy as possible, we look at worst case scenario. The worst case scenario in this case is that the patient, unfortunately, may have been reinfected, or the test result is showing the previous infection. We don't know which, but let's treat for the worst case scenario. However, when we're documenting the incidences in WEDS, we don't know for sure which it is. And so we always say, well, there's a real possibility this could be the previous infection. And therefore, we're going to attach the report onto the previous infection. We're not going to create a new incident in WEDS. If the patient has had a reactive test result greater than 30 days from completion of treatment, determine treatment, and any new exposure with a patient interview, use culture testing can determine treatment failure as well. And after 30 days, then you can start considering the possibility, yes, this is an actual new incident. Let's document this in WEDS. And Megan will now go over excellent ways of documenting different items in WEDS.
Okay, I'm not as tall, so hopefully I'll just stretch my neck a little bit. Okay, so I'm gonna go over the treatment documentation, STI interview status, and STI closure guidance. Also just want to reiterate that we all know that you are juggling a lot of different hats. I think a lot of things are going on, so we're more of just reminders and just letting you know because you're taking the time to do this, and we want you to do it the right way so that you don't have to go back and fix it. We don't have to go back and fix it. Your time's worth it, so we want you to be able to do it in the right way. So the treatment documentation for chlamydia and gonorrhea only. This is just a reminder. I'm sure most of you know the treatment recommendations for chlamydia, but the top CDC recommendation is the doxy of 100 milligrams 2 times a day for 7 days. Azithromycin is an alternative that we see quite a bit documented as well. And then just knowing too, if there's any special scenarios like allergies or anything like that, just to refer to the CDC guidelines, treatment guidelines. Or if maybe the guidelines isn't specific enough for you, definitely reach out to us and we can help choose a good treatment. Same goes for gonorrhea here. Ceftriaxone, 500 milligrams for those less than 330 pounds. And then for those that are greater than 330 pounds, we recommend the ceftriaxone 1 gram. Again, there are alternatives out there. These are just first line. We want these ones to be used first. Again, any special scenarios, refer to those treatment guidelines. One thing that we've been working on the last couple years at the state is our gonorrhea treatment quality assurance and quality improvement project. If you're not aware of what this project is, we basically take all gonorrhea records and any of them that have either no treatment documented in them, maybe there's the wrong treatment documented, or maybe there's just a special scenario. They got something really wonky for some special reason. We look all into those one by one. We look for treatment in other sources like Wishin, and then we document that. For treatments that we don't find through other resources, we contact providers and facilities, and we're asking them for that information. And when we ask for that information, we also are providing education on how to report that information to us better, because we don't want to have to call them every time on all of these cases. So if you have providers that that aren't doing that, I definitely recommend to send that message along. We're trying our best to educate. I will say we've been really successful on getting treatment from folks, but just the reporting part is we're lacking in that. So still working hard on that. And we lost a lot of our DIS at the end of last year, so there's not as many people working on this project now. So it's going to be as capacity allows with the people we got left. Now, interview status, and this does exclude HIV because they have their own fancy form. So when documenting interview status, we want you to use the following sections. All these sections are located on the intervention tab in WEDS if you are familiar. So the sections we want are the patient contacted regarding results, STI reporting and interview information, STI interview dates and period, and attempts to contact. So the first one that I want to talk about is the patient contacted regarding results. So this one's an important one in more than one way. So if providers are sending you reports, we want them filling this out because you need to know what kind of phone call you're going to make. Are you breaking the news to this person that they have this STI? Because that's going to change your phone call length probably 5 to 10 extra minutes. And if you know ahead of time that they already know their results, you can jump right into partner services and start getting all the other questions answered that you need instead of focusing on the education of what the STI is and how they may have got it. But also same for local tribal health departments, filling this section out too, just knowing that you contacted them at that point. And then also for emergency situations, if you happen to not be able to come into work for a week, your cases need to get pushed to someone else, they kind of have an awareness of whether they've been contacted or not and what they need to do with your patient. STI reporting, interview information. There's quite a few different categories in this one, but they all have a purpose, I promise. So detection method. So basically, why they were tested. Did they go in just to get a screening done like they normally do every 6 months, 3 months? Or was it, they partner said, hey, you need to go in and get tested. I've been exposed. And then type of facility. So where did they go to an STD clinic? Did they, get tested in a jail? Things like that. And then next section is more related to like the type of investigation that was given. So did you do partner services or not? Kind of goes into that with that partner service follow-up type, whether you do full, partial, or just treatment verification. And then for the interviewed section, basically documenting if they've been interviewed or not, which I'll go into. So if they've not been interviewed, there's a drop down option to select whether they maybe were unable to locate, maybe they just straight up refuse, don't want to talk to you. That happens. And then other, special cases as to why they're not interviewed. Excuse me. And then if they were interviewed, place of interview, so whether it happened over the phone, maybe they came into clinic and talked to you, or maybe you went and visited them at home. So one thing that I like to say about this place of interview and these specific questions is if you have someone that has history of this STI and they keep coming back, and you can go back and look and be like, well, how did I contact this person previously? Are they a person that I have to go to their home every time because that's the best care that they can get? You're going to know that ahead of time. You're going to know the amount of time that you're going to have to put in for this individual by having this documented. And then STI interview dates and period. So this is basically a section where you're going to do who's assigned the patient, when they were assigned the patient, when the interview took place. This is also a great place for emergency situations. Again, if you happen to leave or can't come into work for some odd reason, your cases can get pushed to someone else. They know where you're at in your casework. Um, so, and then the next one, attempts to contact. This I feel like is a very, very important question or section. So you're going to be documenting any attempts made with patients, providers, labs, basically to know what's going on in the investigation that you're doing. So when you're documenting, you're not only just checking the box, you're putting comments in of how your conversation went. So yeah, you called the provider. What happened when you called the provider? Are you waiting? Did you leave a voicemail with the nurse team to talk about treatment, or did you talk to them, you coordinated treatment, everything's set up, patient just needs to go pick it up? Things like that need to be documented here. That way you have an understanding of what's going on, because you're juggling a lot of other things. You go back and be like, well, I called this person, but I don't remember the conversation I had with them. And then same goes too if maybe they call your local health department and they talk to someone else, and then that person documents in your case for you. They need to put those notes in there for you so you have an awareness of that conversation as well. Um, so very important to have that. Also, again, emergency situations, you'll know what's going on with your cases if they need to get pushed to someone else. So STI closure guidance. So closure guidance, this is going to be in relation to disease incidences and contact investigations. So we've noticed a lot of variety of different closures that are happening. So we're just trying to get everyone on the same page and to be using the same things because there are ones that are more appropriate to be used. So regardless of any partner service type you're doing, whether you're doing full, partial, or just treatment verification, you're finalizing the case out. So for process status, that's going to be your final or closed, depending on whether you have a DI or CI. Your resolution status, that's going to be your confirmed, your probable, suspect, not a case options. If you're not sure, I'm pretty sure a lot of them are automated. I think they go straight to confirmed typically or stay at suspect. But if you're not sure what that status should be, there is a section on the lab tab under confirmation criteria and resources. There's explanations on what each one means and which one to best choose for the situation that you have. And if there is a situation that doesn't quite match, reach out to us at the STI unit. We would be glad to help you pick the best one. And then final disposition, this is the one that we see the most different. So final disposition, I just went through all the interview stuff. What we are seeing right now is that the final disposition is being based off of interview status. That is not what we want. We want interview status to be documented in that interview section. It's there for you, has tons of questions for you if you want to fill them out. And then, so final disposition should be related to treatment, whether they were brought to treatment, previously treated, or not treated. And I'll get into a lot of the options that you have available. So the first two, preventative treatment and refuse preventative treatment, these are going to be used mainly for contact investigations. So for example, preventative treatment, you contact a partner, they go in, they get testing, they come back, the testing's negative, but based off of history, they get recommended to have preventative therapy. They get it, great, preventative treatment given. Refuse preventative treatment, same kind of scenario. They get the negative testing, they get recommended the preventative therapy, but yet they just don't want it. They don't think they need it, so they refuse it. Infected brought to treatment. This would be a good scenario when you receive a patient in WEDS, that you help the patient get treated by working with them or the provider. So you call the patient, be like, hey, you have this. Okay, what do I need to do to get that taken care of? Oh, you haven't been contacted about treatment yet by your provider? Okay, let's get that set up for you. You're telling them what they need. You're assisting them with getting that treatment. Same if you're contacting the provider first. If they haven't prescribed it yet or they don't know what to prescribe, you're assisting with that. You're getting them treated. And then infected, not treated. So if testing shows that the STI is there, but maybe they made an appointment to go get treated, but they don't go in. Okay, they're not treated at that point. Or say provider gave them the wrong dose. So say for gonorrhea, they got 250 milligrams IM instead of 500. They're not considered treated at that point. Or maybe they get something totally different. Maybe they get doxycycline for gonorrhea instead of ceftriaxone. They're not considered treated at that point. Yeah. Okay. Previously treated for this infection. So this is a good example for when you receive a WEDS report and provider or client proves that treatment has already been administered or that they had already started it before you even made contact with them. So if you call provider first, they say, yep, I already sent in the doxycycline to their Walgreens. They just have to pick it up. Okay, great. Call the patient. Yep, I picked it up 2 days ago. I'm on day 3. Okay, great. They were previously treated for the infection. You didn't assist them in getting it. You didn't assist them in getting it prescribed for them. Not infected. This is going to be one that you're going to commonly use for contact investigations as well. So typically a lot of the WEDS reports we get, they are positive for the STI that's coming in. So not common that you're probably going to see this on DIs, but it could happen for false positives or other special scenarios. So just keeping that in mind. But so negative testing and no preventative therapy was provided, not infected, no need to treat. Insufficient info to begin. This is kind of a catch-all for those that have an example of like indeterminate results. I hope that you're still contacting them to let them know that they have indeterminate results and that they need more testing or retesting to be done. But if they refuse to go in for that testing, then obviously insufficient info. Unable to locate. This is one of the top ones that is being used as a final disposition. For CIs, it's fine. For DIs, we do not want this being used. There are better options. Again, we want it to be more treatment related. So the other dispositions that we kind of discussed, previously treated, infected, brought to treatment, or not treated. Those are going to be your top three that you're going to probably be using the most. And then the next one, successful interview, again, another one that's popularly used in the found disposition. Don't use this in that section. That interview status area is there for a reason. Document all that you have there. Let's keep file disposition related to treatment. Located, refuse examination. This is going to be related to CIs as well. So you called the partner, they answered, and they're like, oh, I don't believe you. I don't need to go in for testing. Okay, well, I notified you the best I could. I can't make you, can't force you to go in. So you located them, but they refused. Out of jurisdiction. So this one is going to be in the instance of, say you get a patient and they're like, well, I don't live in that county anymore. Okay, get all their locating information, their new address, all that stuff, and send it to the correct local jurisdiction for follow-up. And then once it's sent over there with all the information that you've collected to locate that person, they can change the disposition to reflect treatment at that point. Just want to also reiterate the comment on having locating information. So think about it in the way of if someone was sending you a patient, what would you need to be able to successfully get a hold of them and get in contact with them to notify them? You're going to need name and date of birth. You're going to need address. You're going to need phone number. So just making sure you have all that stuff together, so that what we're all sharing the same type of information with each other. This is a disposition that is kind of a catch-all disposition. I know you've heard it a couple times. We work in the gray area. There are going to be special scenarios. There's going to be special situations that you come across. We just ask that if you do use other, please document why. That way, when we pull our data, we can look into that case specifically and be like, okay, well, this is why they chose other. And maybe too, we look into it and we're like, well, actually, this could fit under a different category, and then we change it for you. But like I said, as long as you're noting in some form or fashion. Administrative closure. So this one I think will be a good example for what Brandon had kind of discussed earlier regarding the prioritization guidance. So if you have a person that just doesn't meet your follow-up criteria at this point in time, this is going to be a good one to be using. Also, again, noting why you're closing it. So say measles outbreak doesn't meet follow-up criteria at this time. Having some type of documentation so that when we go in, pull that data, find admin closure ones, we can be like, oh, well, this was going on at this time. This person didn't get taken care of, unfortunately. It's just the nature of our work. So just that is an option as well. Domestic violence risk. This is not a final disposition we want to be using. It is a drop-down option in that interview section. Domestic violence is something that happens. We do see it. So just documenting that in there in some form or fashion also kind of helps determine why the interview wasn't given as well. And then again, using those more treatment-related found dispositions. Patient deceased, this one we have to keep, unfortunately, we do see it. Pretty straightforward on what that one is. Previous preventative treatment. So this one's a good example for a CI that you have, you call the partner and they say, oh, I don't need to go get testing. My partner provided expedited partner therapy. Okay, previous preventative treatment. You will also probably confirm that with the original patient too. Don't just take their word for it. But that would be a good one to be using for that scenario. And then forwarded out of state. So these are all the ones that you find that either just moved or they just reside, but they come, they have a doctor here that they like to see and they just come over here, but they don't live here. You'll be using forwarded out of state, just wanting you to know that if it is someone that lives out of state, we are wanting you to change the jurisdiction to non-Wisconsin. That's how we find those in WEDS, and that's how we know that they need to be forwarded out. We also want you to, if you find that they live out of state and they have their address for that state, change it in WEDS. That way we don't have to go looking for it, and we can update it all, and we can send all that information to that state that we have. If you talk to that person and get some questions answered too, document that, because we can send all the notes that we have on that person to that state. We want to create good relationships with our surrounding states as well in that sense. So all the good information, all the information we send them, we're going to expect that in return. So just kind of keeping that in mind as well. Kind of goes almost hand in hand with the out of jurisdiction one too. And then also before we get into that, I just want to mention too that there are, if you've seen me on a webinar before, you're probably like, I'm tired of this person talking to me about this topic, but there are closure guidances for these STIs, and there are documentation guidances for these STIs as well. They are currently out of date because WEDS is ever changing and updating. So once they get updated and reflect the new stuff that's also coming into WEDS, there's going to be some updates coming as well. Once those are they happen, we'll update those, and we'll update those or put those documents on the PCA portal for everyone to have access to. You can use them as refreshers. Maybe you have new staff coming in and want them to look it over, or honestly, reach out to the STI unit and we can easily do some type of training session and we can go through WEDS together. Whatever tickles your fancy, whatever you want to do. We're here to help. We want you to use, we know you guys have not a lot of time on your hands regarding when you have a lot of things that you're juggling. So we just want you to be able to do things in the right way so your time is worth it. So yeah, I think that's it. I think I get to it. So yeah, we got a question.
Make you go back slides here if you can. Can you go back to the interview WEDS slide? Because I'll be honest, I am one of those health departments that this is like 5% of what we do. We do a whole lot of other shenanigans. It's me and me only doing all the things a lot of the time. So I think not that one. Yeah, this. To be honest, I've been in public health 10 years and worked across 2 different health departments. I've never used this tab. So this is because I would never consider myself a DIS either. So like this to me was like, this is for the state. So you had something about, it was like what options, not interviewed, what was the reason? So there isn't anything about here about capacity or I verified treatment a different way or any of the things that would often come up for us. Usually we're using an electronic health record and seeing if the provider talked to them about their partners, about getting retested, they gave them the treatment, blah, blah, blah. We're seeing all that in an electronic health record. And if they're not young, pregnant, or whatever, we are moving on. So what would you be using in that scenario?
So like I mentioned, there are new changes coming, and that's going to be a question. It's going to get added in there, or it's going to get added. I don't know how it's going to get added, but there's going to be either a new question with selections, or it's going to be added in the drop down to be chosen. So if that helps and answers your question.
So for now, use other.
Yeah, I would say use other and type in an answer for now. Otherwise, notes are always great to have things in there. So.
I can second what she said on all levels. I think on the next slide, what is the recommended interview period in months? Like, are we just going off of what their reports are? Are we saying go back X amount of time, or what is recommended?
So we go based off of either symptoms or their testing, because sometimes folks are asymptomatic. So 2 months for gonorrhea and chlamydia is the typical time range. It's different for syphilis. I don't think you probably dabble in that much, but timelines are different for that. But 2 months is the recommendation for chlamydia and gonorrhea. So. Greg?
I'm here. Nope. I think you're in front.
Yeah, right. So because we're seeing such a high incidence of STIs in 15 to 24-year-olds, when we're seeing them in clinic, is it recommended to screen all patients annually, or is there any recommendation from the state on how often we should be new partners annually?
I can do it or you. Okay. In some ways, it's sort of an individual recommendation. We know that 15 to 24-year-olds have high rates of morbidity. And so maybe, just out of cautionary, we want to say, hey, an annual checkup, that would be great for you. Some people may not be engaging in, routine sexual activity, and maybe we lessen that. Some people may be engaging in a lot of frequent sexual activity. Maybe instead of just annually, we want to do it every 6 or even every 3 months. And so what we want to do is, and in some ways, we had that wonderful presentation at the beginning, right before this, having a conversation with the patient to say, how can testing protect you? And how often do you want to do it? They answer the question, and then they're more invested into actually accomplishing it. One thing we do know about when you're talking to people after they've had a sexually transmitted infection is that if you start asking them about how they want to protect themselves, one common answer is, I'm never having sex again. I hate this whole process. In reality, it's like, yeah, that's going to fade after a while. They are going to want to have sex again, and helping, communicating with them, letting them and telling them that, saying, I understand how you feel because this process sucks. And acknowledging those feelings and letting them know that, there may come a time in the future you do want to have sex again. So there are some ways we want to protect ourselves. How would you want to protect yourself in the future? So, any other great questions? I think Lorianne has an online question.
Why is pharyngeal chlamydia not advised to be tested?
That's an excellent question. And Dr. Circle always has great answers for us, who happens to be in the audience. And I believe that the testing methods used to try to determine that are not as specific as we would like them to be. So we end up getting like false positives, and it's the testing, because the biome in the pharynx can create false positives. It doesn't create accurate testing, basically. And so that's why I believe it's not recommended. Yeah. I was going to repeat it, but sure. Yeah. No.
I love this topic. Well, it's a quick science moment. They're growing inside of human cells. They can't grow without a human cell. And their favorite cells are, of course, in the cervix type area. They don't like to grow as well into the throat. They're not able to establish as well of an infection there. So when you do detect them in the throat, that could just be transient. They were exposed. There is DNA there. They might not even be alive. But that means that they were potentially exposed. It could be somewhere else in their body as well if you find it in the pharynx. So I wouldn't necessarily screen for chlamydia in the throat. It could still be significant when you find it. They have been exposed to it.
Oh, question?
No.
Oh, okay. Any other questions in person? Do we have any online? Yeah. Oh, well, somebody else had asked that question, but again, we use 60 days, 2 months as the interview period for gonorrhea and chlamydia. Symptoms can make that even more interesting. So Yeah.
All the way to state. So that's the, so maybe a little bit more than 2 months.
Yeah.
I also just I forgot to mention this before I got into the found dispositions. I also forgot to mention this yesterday as well, but the found dispositions aren't ones that we pulled out of thin air. Like these are nationally used. So just kind of keeping that in mind too. We're just trying to get on the same page as everyone else. So just so you're aware of that. And two, with your note of you don't consider yourself a DIS, so you don't answer some of those DIS specific questions. Let us know that because we can rephrase questions that are, we are recommending you to fill out, but you don't think apply to you. We can rephrase them to reword them to be better. I know too, there's been many locals that have reached out and have wanted certain sections reorganized, or maybe they just need some extra resources that are quick right there. So we can definitely look into those things. You just have to tell us and we can work to do that. So just keeping that in mind as well.
And with that, there's a phrase my whole unit knows. You do the best you can with what little you got. Okay. And so, document what you can. And if there are sections on there that don't apply, they don't apply. Any other questions or highlights or recommended sources of funding that we could use? Another question, I believe, online.
It seems that some areas are duplicate charting in WEDS. We charted the 2 months in the interview period and sex partners in the STI risk tab. It would be nice if those 2 tabs communicated with each other.
Okay. Yeah, and as Megan was saying, when we hear about things like discrepancies in WEDS or possible ways of making WEDS better, we love to look into them and determine, yes, is this a great way to do it? Could there even be a better way? Is it an education issue? There are lots of different, we try to look at all of the suggestions to the best of our ability and look at continuing ways to improve it, so that makes it easier, and less likely prone to error. So. Y'all want to take a break? We have one more question okay.
So there's always a lot of talk about antibiotic resistant gonorrhea. How common is that for chlamydia to be antibiotic resistant?
It's an excellent question. Dr. Circle has her hand raised. So.
I just wrote a paper on this. So it's incredibly rare. Incredibly and really, really hard to find it as well. While we've got some wonderful resources, particularly at the Milwaukee Health Department lab, to culture gonorrhea and find drug resistance there, we've got funding for that kind of project. Chlamydia culture and chlamydia resistance testing are incredibly hard to find, especially resistance testing. There are only a couple labs in the country that can do this. We've only found a handful, maybe a dozen total true resistance cases. So in most cases, Brandon put it really well, it's usually reinfection or inappropriate treatment. They didn't take their meds when you see a prolonged chlamydia case. So does happen, but very, very rare.
Yeah, gonorrhea is the one that really likes to be sharing and caring. They like sharing its DNA. They like finding ways to be resistant. And that's why, obviously, we have our Cargos project coordinator here that looks at antibiotic resistance for gonorrhea. The philosophy is it's not a matter of if, it's a matter of when, because we've seen the history of gonorrhea. It has developed resistance to medications over and over and over again. And so that's why we take ARGC very seriously, because if it does happen, I mean, if you think doing disease intervention for gonorrhea is difficult now, try doing it when you don't have great medication to treat it. That's going to be, oh, that would just, make it so much harder. So, yep. Please, knock on.
And there also, again, like with ARGC, we do have DHS ARGC email. So if you do, I think we have it listed on here, but I can definitely write it down for you if you need it, or we can maybe send it out in some form or fashion. So if you do come across one, or you might think it is one, but you're not sure and you need access to like some culture testing, but no one around you does it, we can help coordinate that. So just reach out to us and we can help out. I think so.
Yeah, our website may have that email on its page as well. And if it doesn't, we're going to put it on there. Oh, excellent. Any other questions, concerns, fears, predictions? Okay. Thank you very much for attending.